Welcome again, everyone. This is part 2 of our workshop series, implementation of partnerships for treatment and partner services. Hopefully you all were able to join us for the part 1 that was planning for partnerships. And if not, don't worry, the slides and recording are up, and I can share the link in the chat for the event page where you can access that. A couple of housekeeping items before we get started. This is a 3-part workshop series. This is part 2, which is really exciting. Recording and slides will become available Friday on our event page. And as I said earlier, this is a meeting format. So be mindful, please, of just being on mute. If you have a question, feel free to raise your hand or come off mute. We also have the Q&A option that you can click to the bottom left-ish of your screen where you can submit questions for our speakers. And also you can feel free to interact in the chat as well. Feel free to come off and or on camera as you feel comfortable as well. If you have any needs that you feel will be helpful in you sitting in our webinar and joining us today, please feel free to DM Leo Parker or email him. I did want to cover, there were some folks that had mentioned closed captioning, so I just want to make sure everyone has access to closed captioning here. So if you look at the center of your screen on the bottom, there is a tab that says show captions, and it has a CC on it. If you'd like to enable your captions, you can click that, and it will tell you live transcript on. So you'll need to facilitate that on your end if you want to view captions. If you have questions about that or need help, feel free to message either myself or Leo. Oh, and I did forget also, there will be a survey at the end of the meeting. Thank you to all of you who completed the survey at the end of the first one. We ask that you, again, kind of just complete that survey. It helps us to modify and really curate content that you all are looking for. All right. So just a little overview of where we'll be going today. We'll discuss, kind of just recap our part 1, where we went with that and our goals. We'll think about some logistical considerations for implementation. And Erin Fratto will then be speaking with us. She's our consultant here with NCSD. We'll hear from Pueblo Department of Public Health and Environment. And we're not having a discussion with public health. We're having a discussion with public health from Pueblo County. Sorry for my typo there. And then we'll look at what to expect next. So just to recap, some of our primary goals for this workshop series were to identify needed partnerships, staff, and resources to integrate a set of services into incarceration facilities. Secondly, identify logistics to effectively implement those services. And then our next workshop will focus on assessing ways to measure impact of service delivery. For this part 2, we'll focus on identifying necessary logistics for service delivery. And then Erin Fratto will cover health department partnerships to provide 340B eligibility and other arrangements that ensure STD treatment. Again, if you missed part 1, the slides and recording are up on the event page. You can also go into Google and click travel to NCSD and then our workshop series. And you'll go to, you'll see part 1 and part 2 listed. So in part 1, we listened to Public Health Seattle-King County from Dr. Dombrowski and our DIS, Luis Enrique, about their pilot testing program in their SCORE jail. They discussed their testing workflow, how they followed up on reactive tests and their process for ensuring treatment and notifying partners. They also shared some data from their implementation, and they highlighted that most folks who test positive for syphilis are people who can become pregnant and people, men who have sex with women, with a disproportionate impact on BIPOC. 76% of all newly identified syphilis cases in the jail were actually identified by DIS. So this is something that they identified as working for them. They did note that relationships between the jail program staff and health services are key to how they're implementing their program, and that treatment completion is still a challenge that they're working with. So one of the goals for our our conversation today is thinking about some of the logistical pieces when we're implementing. So these are some things that Seattle also mentioned as part of their process. So some things to think about. Staffing, will there be security clearance necessary? Will there be additional training necessary for staff? What kind of testing are we going to use? Will we use rapid testing? Will we prioritize HIV testing or syphilis or hepatitis C? Will it be all of the above, or are we going to add chlamydia and gonorrhea as well? And how does that impact the treatment options and how we implement partner services? Kind of coming off of some of the questions that you all asked, not only within my NCSD conversations, but also from our last webinar, questions around who will have access to these test results? How will the information be shared between jail health services and the local health department? Will we have access to their EMR, or do we need to designate a point person within jail health services that will connect with? What does that look like? Many of you asked about the costs and who will take responsibility of treatment, which Erin Fratto is going to dive into today. We're really excited because I know there were a bunch of questions that we actually didn't answer last session because we were going to talk about them today. So hopefully a bunch of those will be answered today. And then also thinking about optimizing partner services. Should all cases identified within the jail setting be followed up on? What type of follow-up will happen? Are we going to prioritize treatment? Are we going to prioritize an interview? Are we going to prioritize partner notification? Or will it be by group impacted? For example, are we only going to follow up on people who can become pregnant? So just some things to think about, and I'm sure these are all a wide range of questions that you all have considered and are probably still kind of, processing, like how can we kind of get to some answers for these. I wanted to, before I introduce Erin, I did want to kind of get an idea of who all is with us. So I'm going to launch a poll here. Firstly, which best fits your role? And secondly, what stage of implementation are you or your program in? So I'll give everyone a minute or two to kind of sort through that and fill that out, and then we will move to Erin. And actually, while we're all filling out this, I can actually introduce Erin, I think, while y'all are still filling this out. So Erin is our consultant here at NCSD. She provides subject matter expertise and project management and programmatic support to our work here. She brings over 12 years of DIS and STD director experience, where she's previously led her state's HIV planning group and served as the state level 340B authorizing official and primary contact. So she's definitely our point person for 340B, and I'm sure she'll be able to answer 99% of your questions. In addition to being a sexual health advocate, Erin is a harm reductionist and medication access enthusiast. She holds her Master of Science degree in Health Education and Promotion and is a certified health education specialist, certified rapid HIV/HCV testing counselor, certified correctional health professional, and a certified sexual assault counselor. And I'm going to give another moment for folks to wrap up here on this poll. Looks like 75% of you will have answered so far. Okay, I'm going to go ahead and end this now. And I will actually share the results so we can kind of get an idea of where we're all at. So it looks like 30% of us on the call are DIS, with 20% of us being STD program managers and some of us also being clinical staff. I'm kind of curious what the something else is. If you all feel comfortable and would like to drop that in the chat, we'd be interested to kind of hear where everyone's at. And then secondly, what stage of implementation are you or your program in? So it looks like we're all pretty much across the board. So this should be an interesting, robust conversation we're looking forward. Cool. All right, Erin, I will leave it to you then.
Great, thank you. for all the housekeeping and setting us up well. Was that a dog bark I heard right at the last minute? Okay, cool. Well, welcome everyone to this webinar series, or I guess meeting. We're in meeting format. I'm going to just do a really quick level setting with you. I use the term correctional facility. Incarceration facility is what's used for this series. So I use those terms interchangeably. Please give me grace. 340B also calls the 340B designation that's applicable to our line of work the STD designation. So I will also be using STD and STI interchangeably. And again, thank you for your grace in that. So correctional facilities is a term that is an umbrella term that includes jails, prisons, or any other detention facility that's used to house people who have been arrested, detained, or convicted by a criminal justice agency or a court. It's any place used for the confinement of persons charged with or convicted of a crime or otherwise confined under a court order. So correctional facilities is that all-encompassing term. A jail is the type of correctional facility generally used to detain people awaiting trial or sentencing. For those who have been sentenced, jail sentences are usually shorter than those incarcerated in a prison. Jails also house smaller populations than prison and are often under the jurisdiction of a local law enforcement agency. Prison, conversely, is a type of correctional facility that incarcerates individuals who have been convicted of a crime. State prisons are operated by individual states, and they often have their own legislation regarding the prison system. Federal prisons are overseen by the Federal Bureau of Prisons and have different purposes and security levels. So we're going to be talking about apples and oranges today. And when it comes to 340B, it's the principles are the same across correctional facility types, but the struggles that you experience with jails versus prisons are very different. So we're going to talk about that as well. But I just want you to kind of know the terminology that when I throw out this terminology, when I speak about correctional facilities, it's not just prisons, it's not just jails, it's both of those. So we'll dive right in. I'm preaching to the choir. You all are here because you are either already working with a correctional facility within your jurisdiction, or you know the importance of working with them and are trying to improve your work. I wanted to outline exactly how important these relationships are and how valuable this programmatic work is. The United States has the highest incarceration rate in the world. We incarcerate approximately 6.6 million people in some form or another. CDC has issued recommendations for correctional settings and detention settings for intake and throughout the course of incarceration. So there's really public health initiatives across the country that are supporting this work. Correctional facilities also provide an opportunity for high impact interventions to be implemented. This is a captive audience, whether they want to be or not. And many health department viral hepatitis, HIV, and STI programs have established collaborative partnerships with correctional facilities within these jurisdictions. The only way we're going to address this endemics in our communities is to work within correctional facilities. This is also a really profound quote that is going to relate to the 340B program that I'm going to be talking about. But public health departments, while we're low resourced and often underfunded, we have resources to share with correctional facilities. And I highlighted the other resources piece in this quote because we're going to be talking about, sometimes getting creative and providing access to a very valuable federal program, which is the 340B drug pricing program. But correctional facilities have been partnering with public health and providing public health functions for decades to some degree. This might include immunizations, TB skin testing, health education classes, STI screening, HIV opt-out screening, to whatever capacity across the jurisdictions. And some states even have legislation that outlines what public health functions correctional facilities need to implement and maintain. And the point of the correctional system is to rehabilitate, meaning that most folks are going to be leaving incarceration at some point and reintegrating back into society. So this is really a crucial point for public health to kind of fine tune the interventions that are happening within these facilities. So in talking about our partnerships with correctional facilities, I'm really trying to set the stage for discussing supporting the correctional facility and accessing deeply discounted medications by utilizing the 340B drug pricing program. The 340B drug pricing program is a fairly complex federal program that gives covered entities access to deeply discounted medications. Some of you are familiar with the 340B drug pricing program. Some of you might not be. We had a lot of questions on our series, our first session about the 340B drug pricing program. So I kind of wanted to do some basics here, but it's a federal law. It requires drug manufacturers to offer discounts on medications, on outpatient medications. And first and foremost, it's a drug pricing program. It's not a funding source. It doesn't provide free medications, and it can't be used for vaccines, but it does greatly reduce the cost of medications, and especially the medications that are needed to treat sexually transmitted infections. This program was enacted by Congress and signed into law by George W. Bush in '92. And eligibility is really dependent upon receiving federal funds that are authorized by certain sections in the Public Health Service Act. So I'm going to kind of talk you through that as we talk about it. But really, this is a program that if you are dealing with STD treatment, STI treatment, treatment for incarcerated folks, this is a program to definitely be aware of and educated on. The 340B drug pricing program is very large, and it's not just for health departments. It's way bigger than us. The bulk of those enrolled in the 340B drug pricing program are actually hospitals. Hospital types include critical access hospitals, disproportionate share hospitals, children's hospitals, freestanding cancer hospitals. There's probably a hospital within your community that is utilizing the 340B drug pricing program. They're all over. About 1/3 of all US hospitals participate in the 340B program. So you'll see here on my list, there's hospital types and then there's grantee types. And STD programs fall under the federal grantee STD clinic category. And this is also inclusive of any program that receives funding authorized by Section 318 of the Public Health Service Act. So this means that all major CDC infrastructure grants are providing eligibility to the 340B drug pricing program. This includes the viral hepatitis grants, the HIV grants, the STD grants. There's over 24 NOFOs that are authorized by Section 318. We call this statutory authority. So if you're not sure if you're receiving funding from a Section 318 grant, you can always go to a NOFO, a notice of award, and search for that statutory authority. So Section 318 is what you're looking for. But anybody who receives eligible funding is eligible to participate. So when it comes to correctional facilities, when somebody's incarcerated, Medicaid, Medicare, employer-sponsored and individual plans, and the Red White program are typically unavailable to people while they are incarcerated, leaving correctional facilities responsible for significant medication costs. So now when we're talking about, we want correctional facilities to start screening very quickly the question of who is providing treatment, how are we going to pay for this treatment? That conversation comes up pretty quickly. And correctional facilities are not 340B eligible on their own. Correctional facilities need to partner with a hospital or grantee who receives 340B eligible funding to pass that eligibility on to them in order for them to participate in the 340B program. So this kind of, again, wrapping this up in a bow, when STI programs pass on 340B eligible support from their federal grants to support the services within the correctional facility that are within the scope of their grants, they may be providing 340B eligibility onto that correctional facility, whether it's a jail or prison. So it's kind of rolling downhill. The eligible funding comes to the state level, that might come to the local level, and that might in turn go to a correctional facility. It also might go straight from the state level, straight over to a Department of Corrections or a prison system. So it can happen in varying ways, but I just wanted to really point out kind of that eligibility piece. So STI programs can formalize these STD 340B partnerships. So really the first step in this is identifying the key stakeholders at the administrative level. Some folks don't know about the 340B program, so we're starting at the basics of educating about this program, educating about what it does and eligibility. And through these partnerships, through health departments and correctional facilities, you can really set clear expectations. And with this participation in the 340B drug pricing program, correctional facilities now have the ability to purchase deeply discounted medications to treat those diagnosed with STIs, viral hepatitis, or HIV within their facility. But you as the health department now have the ability to set clear expectations and encourage public health practice because you are providing that eligibility to them. So this is an opportunity to expand, offer, or improve treatment and prevention within the facility. We call this a big carrot. There's a big carrot for them to improve their public health practice and participate in this drug pricing program. And I'll kind of highlight a few things in a few slides as well. But you're wondering maybe, how do I get a correctional facility to participate, or how does this work as far as eligibility is concerned? Like I said, anybody who receives qualifying 340B funding is eligible to participate in the 340B program. So covered entities must have a financial relationship with a qualifying Section 318 program, and that's eligible for 340B. And they must either receive direct financial support or receive in-kind contributions supported by that qualifying funding. Now, STD programs are not flush with money, even more so recently, but a lot of in-kind contributions may be available to your correctional facility. So think as a DIS, as an STD program supervisor, as that other category. Are you giving a correctional facility anything? Are you giving them condoms? Are you giving them brochures? Are you giving them time? Are you giving them any other resources? Are you giving them a lab allocation? The most frequent support that's awarded to correctional facilities is personnel to implement disease intervention, partner services, outbreak response readiness, or other grant-specific activities or functions. Sometimes health departments might already have grants, contracts, or agreements with a correctional facility. Sometimes they're establishing these, as a new partnership, as a new relationship. Sometimes support is provided to a correctional facility from a health department to support specimen processing. It might be for HIV confirmatory test. It might be for viral hepatitis. It might be, a chunk for chlamydia gonorrhea screening or syphilis testing. The health department might be providing support, monetary or in-kind, for vaccinations or immunizations. And like I said before, it might just be materials and supplies for the prevention, treatment, and care of the communicable diseases that are within the scope of the grants. All right, once a correctional facility is eligible, they would enroll themselves in the 340B program. So the health department is responsible for really being that gatekeeper of, are they passing on eligibility? Are they providing direct funding? Are they providing in-kind support? Are they granting access to the 340B drug pricing program? Once that is done, a correctional facility would be the ones to enroll, and they would be the ones in charge of their own 340B program. So they are then responsible for only serving 340B eligible patients. So a patient becomes eligible for 340B medications when each one of these components on your screen are met. This is fairly easy for correctional facilities to do, especially number 1 and 2. It's usually the legal requirement and responsibility of correctional facilities to provide adequate medical care to those incarcerated within their facilities. I'm not going to say great medical care, we're going to say adequate medical care. The correctional facility, and this also includes any medical contractor that they might have, that also counts. So the correctional facility maintains medical records on all of their incarcerated individuals. So that's number 1. And 2, correctional facilities have medical personnel on staff, or they pay their medical contractor to provide that adequate medical and healthcare services. So when a correctional facility utilizes a paid contractor for medical services, the correctional facility would still be the covered entity, because that correctional facility is still the one that has the responsibility to provide the care to the patients. Instead of employing medical staff, they are now just employing a medical contractor, but that responsibility remains the same. Number 3, and here is where health department administrators have discretion. So the patient has to receive a service or range of services within the scope of the grant that's providing the eligibility. So in the STD program perspective, this would mean that they received a screening, a test, a sexual health assessment, something that is in line with the purpose of this grant. This often happens upon intake. It should happen upon intake. Like I said, adequate medical care. We're not talking about great medical care. It varies across jurisdictions and it varies across correctional facilities. But really, the health department can help the correctional facility improve their processes, because once you have an eligible patient, any medication that that patient might need can be covered by 340B. So there's a financial incentive for correctional facilities to, one, participate in the 340B program, work closely with their health department to ensure that eligibility is in place, and three, continue to do good public health work so they can continue to save money. So money talks and walks. Money is usually at the root of motivation for most people, and the 340B drug pricing program really provides that for correctional facilities. These are some states that have 340B Department of Health and Department of Corrections partnerships. I see more prisons than jails participating for various reasons, mostly because Department of Corrections, the prison level, just have more infrastructure. It's a state level agency. There's more money, there's more staffing. People are there for a longer amount of time. And I'm sure USDIS would rather work with a prison than a jail as well. They're just a little bit more stable. Jails, frequent flyers, they're seeing people, quicker. They come and go. The revolving door swings a little bit faster. Staff also has a quicker turnover, it seems like, and there's just less administrative capacity. So for whatever reason, that's my own opinion, but for whatever reason, there's more prisons participating right now than jails. But I did want to highlight that there are jail STD covered entities active utilizing the 340B drug pricing program. These are programs that are accessing medications at deeply discounted costs and serving the people who are incarcerated within their facilities. And like I mentioned, money is a big motivator. And once a 340B patient definition has been met, that patient is eligible for any medication that is clinically indicated. So if I come into a correctional facility and Sonia is the nurse and she's working there and she screens me, she takes my sexual health history, she has me pee in a cup, she swabs all the things, she provides me great care that's within the scope of the STD grant that's providing the jail's 340B eligibility. Any medication that I might need can be covered by 340B. So she's going to treat my syphilis with 340B. She's going to treat my cellulitis in my arm with 340B. She's going to get my diabetes under control with insulin purchased with 340B. She's going to save about $10,000 serving me because I'm now an eligible patient. Again, the only caveat is that this must be an outpatient medication. And again, we're talking about a carrot. We're talking about saving lots of money. We're talking about expanding treatment. Correctional facilities should reinvest the money that they save on these medications back into programming that is in line with the scope of the grant that is granting their eligibility. So lots of correctional facilities are using this to expand testing, to expand treatment. The 340B drug pricing program is allowing prisons to treat for viral hepatitis now, thanks to lawsuits and patient advocacy. We're seeing lots more treatment in prisons for Hep C. But with these medication savings, some correctional facilities are implementing new programming within the facility. They are hiring linkage to care. They're doing better bridging services. They're doing better case management. Money savings or cost savings should be used to support things that are going to end this endemic. So I think I'm getting close to my time, but I just wanted to note that this is specific to the STD 340B designation type. 340B has other designation types, including hospital types and FQHC types. I'm not an expert in those. So this guidance is specific to the STD designation type. And when implementing 340B programming, covered entities should always use their own judgment and legal counsel. I'm going to drop my information here. Like I said, 340B is a complex federal program. I did not give you an in-depth 101 on the 340B program. I am happy to talk about your own unique situation. I'm happy to give you tips and tricks about partnership development. I'm a safe space to answer any questions that you might think are dumb, but are probably not that dumb. So there's my email. Feel free to connect, and I'll be on for the rest of the webinar as well.
Thank you so much, Erin. Hopefully that answered some of our preliminary questions. Please do feel free to reach out to Erin, and anything that you do think of along the way, please feel free to add your questions into the chat or the Q&A. And you can also add them to the post-meeting survey. That way we can kind of circle back on them as well to kind of close the loop there. I want to now introduce our guest speakers. We have Corey Westwood from Pueblo Department of Public Health and Environment, and Elsa Huber from Colorado Department of Public Health and Environment. And she's a DIS. So Corey is the public health nurse who focuses primarily in Pueblo County Detention Center, where she works closely with Elsa to provide field-delivered therapy for pregnant people and people of reproductive age who can become pregnant, and their partners. And Elsa is the DIS at the Colorado Department of Public Health for the past 3 years. And her efforts focus on maternal and congenital HIV and syphilis disease investigation. I will turn it over to you all. Feel free to kind of elaborate on where you are, who you're, kind of your background, and I will turn it over to you.
Thank you, Sonia. I'm Corey Westwood. I'm the public health nurse here in Pueblo County, Colorado. And we have started working with the Congenital Syphilis Elimination Grant from the CDC. So I will have you go ahead and advance the slide, and we'll go over some of the numbers that I've seen so far. We started testing in Pueblo County Detention Center in February of 21, I think it was. So far, I have screened 485 individuals. That's women of reproductive age in the jails. And you could see where we fall right now. 62% of those inmates were 25 to 39 years old. Go ahead and advance that, please. So right now, my positivity rate just in that population is 27% positivity rate with rapid syphilis tests. That's just the finger stick that we're doing to get the process started. 5 of 20 inmates that we have seen who are pregnant are also positive as well. So that kind of holds true with 25% positivity rate in that population. Right now, I'm holding a 73% treatment completion rate, and we'll go over what the challenges are with that as well pretty soon, but it's gone up. It's between 69 and 73 is our treatment completion rate inside the jail. Go ahead. So this is just an anecdotal slide of numbers that have jumped up here in Pueblo County alone, not just Colorado. So this is what caught the eye of the CDC to get us this grant for the congenital syphilis elimination. And I'll let Elsa explain a little bit more on that.
A lot of people had questions, why the massive increase here with these numbers, and we don't have great answers for that. I'm sure it's not what you want to hear, but there was not an increase of testing in 2020 and 2021. We just started going into the jail in 2022. So because of the pandemic, testing efforts were drastically lower. We have seen, and again, this is very anecdotal, but we have seen, just a massive increase in our drug using population, specifically here in Pueblo, which can have ties to higher STI rates as well. But we don't have great answers for why the jump is so high. And Corey's efforts in the jails are definitely getting us some more numbers. But again, Pueblo County, it's a small county relatively for Colorado. So it's our pilot program. We're just getting started. So, and I know that now that we're into 2023, testing efforts by other agencies and nonprofits are starting to go up. They're getting in the field more and things like that. So we expect the numbers to go up even a little higher here in 2023.
This is our data that we've collected so far. So Pueblo County in 2020, we had seen 7 congenital syphilis cases. Colorado had 24. It went up in 21, 13 of 35. 22, we saw 11 of 33. And this is as of first quarter of 23. We have Pueblo County has seen 2 out of 5, which those numbers have changed already. So we're still evaluating that piece, but it's in the first quarter of the previous years, we had not seen that. We had seen 7 at least already from that. So right now it looks like, you know, we're having some impact. So it's exciting to see that go down a little bit. So here's a scope of work of what we're doing with the grant. So the goal is to address the rising numbers of syphilis cases in Pueblo County with the focus on congenital syphilis. The scope of work is we're partnering with the Pueblo County Detention Center to provide syphilis testing and treatment to female inmates of childbearing age between 18 to 45 years of age. We did develop protocols. There's one full-time RN which is me. I'm dedicated to testing and treating in the detention center. 1 day a week, I provide screening, testing, and treating at intake at the judicial building. So that's where they get booked, and intake is done through medical, which is NAF care down here in Pueblo. So they do the medical screening and intake, and I'm there doing that. And then they get transported over to the actual jail, which is just a couple blocks down the way. So 3 days a week, I am there providing the same thing, screening, testing, and treating. And Elsa is with me on Wednesdays. She conducts the interviews in the detention center with me. And then we also started field delivered therapy in August of 22. So this is the process that we came up with that we are always evaluating and changing. During intake, women of childbearing age had the following tests performed. So after screening with NAFCare Medical, they agree to screening, testing, and testing. So I do a rapid syphilis test, and since we are there, we were able to provide rapid HIV testing, a urine, gonorrhea, chlamydia, and a pregnancy test. And every female inmate able to have children gets a pregnancy test going in through intake anyway. So we added all of that to our testing piece. If the rapid syphilis test is positive at that time, I do a confirmatory blood draw, and I also administer first dose bicillin. Elsa is notified if she's not there with me. She's not at judicial with me, but we get a list going of who she needs to interview. And then those occur when she's with me on Wednesdays at the jail.
I will say that Corey started out very simply going into the jail with just the rapid syphilis and HIV testing, and then built on from there as the facility got more comfortable with her processes. So she started off smaller and then grew her testing efforts as well.
So here is those numbers again, just the current data. So we started February of 22, 485 women screened. This includes all women meeting criteria, and these are unduplicated. Unfortunately, working in detention center, we see people come in and go back out and come back in. So these are all unduplicated. 27% positivity rate right now with the rapid syphilis. The caveat with that too is people do come in with history of syphilis that's either untreated or is a new infection as well that we've partnered with ELSA through the state. So we get history as well when they come in. I do have 73% treatment completion rate, 2 congenital syphilis cases so far through March that we were not able to completely treat. We did start field delivered therapy in August of 22. So 14 of 16 patients so far have completed bicillin treatments ×3. 4 of those were pregnant. Of the 4, 1 actually did get reinfected 30 days prior to her, or in 30 days before her delivery. So she was a newly infected case, or reinfected case again, and baby was treated at the hospital as well and was counted as one of our congenital cases. Of that, 3 male partners have been tested, 2 have been given a first preventative dose, and 1 started a 3-dose series. So the challenges that we've seen so far, the completion of treatment series. So women are released from the detention center prior to completion of treatment. We're not notified of when they get released. So we have to do some digging around through the website that we can search for them. And also when we get to the jail and pull our roster and see where they're at. So that's been the main reason why they're not completing it, because once they're released, we give them all the information during the educational piece of the screening on who to call and where to go, and we get contact information and try to reach out. And Elsa's great about doing all of that. We just lose them to contact. Also, just to go off of what Erin was talking about 340B, cost of treatment is 400 times more at the facility, at the detention center, to get bicillin, so they don't carry a lot of it. And we have tried to get them to get into the 340B program. Unfortunately, there's been a lot of turnover, so that always holds everything back. So they still do not have a 340B. They don't have that going for them just yet. We do provide follow-up to our clinic here at Pueblo Department of Public Health and Environment for other STI treatments if they need it. We do family planning as well. And we try to refer them in if they are able to come and see us here. And then, just like I said before, that attempt to contact made after release, it's, we try to find them as much as we can, but we just lose them until eventually they end up back in detention and we're able to restart them, which we were able to do and actually this morning. So we tried to reach out to them as many times as we can to get that going. Written expectations and roles agreed on by both parties. An MOU or written agreement is in place to get that prior to initiating the grant. Since we were a pilot program and we developed everything, out of, not thin air, but close to it, we didn't get that MOU in place initially, and we finally were able to get that going. After the grant was received, we PDPHE and the detention center worked to create a plan and implement processes that were feasible for both parties. Initially, when I started, I was able to shadow the intake nurse and medical at the detention center just to see what their flow was and get a process going to see where it would be feasible to add the screening and testing to their flow. And then the scope of work right now is only focusing on women of childbearing age. So we're not able to just go out and screen, test, or treat males unless they're named partners. So that is is a big challenge, as well as a lot of these females are not giving us partner information unless, they say, oh, he is also here at the detention center, so you can give them a call down to the clinic, so we can do that then. But including males in the testing and treating could have a very big impact on reducing the congenital syphilis rates here in Pueblo. So that's what we've been doing here. Any ideas or questions that you have would be very helpful. We're still looking to find funding for male testing, which would be great here. But we're not there yet. So if you have any ideas, that would be great as well.
Thank you both so much. I think we can go ahead and dive into some questions. I see that there's some questions both in the chat and the Q&A, and we can go ahead and go into some of those. Let's see. I'm going to start with the ones in the chat here. So someone asks of Corey that they'd love to see your protocols if you're willing to share, and they put their email address in the chat.
So we're working on our dissemination project now. Oh, sorry about that. Did you?
Go ahead. Go ahead.
So we're working on the dissemination project currently. So our medical director has signed all of the protocols that we've updated. So once that is able to be sent out, you can reach out to me and we can talk about that as well.
Thanks. Before we kind of jump a moment back to I see 3 questions about 340B. I did want to ask a question that was brought up from the last webinar, and then also in my NCSD, there was a thread happening. And Elsa, this question would be for you. There were some questions around interviewing specifically in jails. Can you speak to some of the challenges that you faced, kind of improving some of those outcomes? I know you mentioned that you're not able to, and if I understood correctly, you're not able to test you're not able to test in males unless they've been named by someone. Is that right? So
Correct.
how does that impact kind of where you're at? And then of course we know interviewing in jails, it's also challenging to kind of identify people who have been exposed or who are named partners. So can you talk a little bit about that?
Yeah, I think that interviewing in the jails, there are definitely some challenges. It mainly comes with a lot of the people that we interview have a lot of anonymous partners due to sexual exchange or sex work. So that can be definitely a challenge. Like they might have a street name for someone and a general area of where that person stays. So we definitely make attempts on those people, but it can be really hard to locate. As well, keeping like DIS and Corey's safety in mind when we're out in the field. But for a majority of the part, it is really hard to interview when someone's in an active withdrawal, which a majority of our clients are. And the good thing about interviewing in a jail that makes it a lot easier is you get multiple attempts to interview them. So I'm with Corey once a week, but it's generally every time I'm with her, she's doing Bicillin treatments. So in the, I don't know, like 95, 99% of people need all 3. They're late latent. So I'll see them for 3 weeks in a row. So for example, if someone's withdrawing really bad and they're giving me very limited information, you're able to build really good rapport over a 3-week time period. A lot of people we've seen before as well. So when we come in, they know what we're there for. They know our names, things like that. They have a built-in rapport with us. So that's the part that makes it easier to interview that first time. If you don't catch partners or some of the risk factors, you can ask all those questions again when you re-interview them. And I ask about partners every single time too. So even if they gave me 1 partner, I'll ask them for the following 2 Bicillin doses. You know, anyone else that would benefit from testing, even if it's not a partner, if it's a friend or family or whatever that you're worried about. And people have, you know, they're like, oh, my sister, she's showing signs or symptoms of this, this, and this. So the more time we spend with them, the more comfortable they are with us. They know we're just there to help them. And so that's the good part about interviewing in the jail is you get a lot of face time with them. As opposed to some of the interviews like DIS regularly do over the phone. The challenges definitely come upon release. That's, I think, our hardest part for treatment completion, interviewing, finding partners. And I don't know how we can mitigate that any better than what we're trying to do right now. And then the third and final part that makes interviewing in a jail difficult is a lot of people's partners have a lot of history with correctional facilities or people in power. So they don't want to give any names to the state health department. They don't, you know, they don't want to expose them to any more state facilities or state institutions that will come into their life. So even though we try our best to educate on reinfection and so on and so forth, they're still very hesitant for certain partners that might have a deep-rooted history with the state or facilities or whatever it is.
Thank you, Elsa. Someone asks in the next question, or in a question, what ballpark percentage of people do not consent or refuse testing or treatment? And how do you address that challenge?
So we're covered under the umbrella at intake when they consent to medical treatment. They let them know that they're consenting to medical treatment as long as they're in the custody of the Pueblo County Jail. So that covers us for the consent piece. As far as refusals, it has gone down quite a bit. The ballpark number is still a little difficult to throw out there, but the main reason for refusals is withdrawing. But we have been able to get with the detention deputies and let them know that we would like to see them and screen them first before they refuse. Initially, when we first started, they just said the health department's here to see you. Do you want to see them? So we changed that wording to opt out. So to let them know that the health department's here, they want to see you, and let them come in and talk to us first to let them know why we're here. So the opting out process has made a big difference as far as our refusal rates. I've been keeping track of what the refusals are, and the main reason right now is withdrawing. So it depends on when they got booked in and when we're there. We are able to pull rosters and look at those dates and see, so we kind of get an idea of, oh, they just came in last night. They're probably not going to be ready to talk to us, but we can call them back and talk to them and see how they're doing, and give them that option as well of, well, I'll be here, Thursday and Friday as well. I'm going to call you back if that's okay. And they usually agree to that, so they know what it's for. So the refusals since the beginning have gone down quite a bit because of that, and the deputies and the training with with their captain, who has been a great resource for us, letting them know that we do need to talk to them no matter what. So it's been helpful letting the deputies know what to do, and they're very helpful with us when we're there.
Thanks, Corey. I see someone just added a question about partner services. Are you permitted to use phones or tablets for partner services in this setting? One of the challenges we face with partner services in the jails and prisons is not having the option to look at apps or phones for partner info. They are willing to share, we just can't use the electronics in the setting. Any thoughts on that?
Yeah, absolutely. That is definitely another challenge I forgot to mention. We have people almost every time say, I have this partner, I don't know his phone number, or I don't know their phone number. And another thing that Corey made was a rack card. So it's got, and it's given to them upon release, so they don't have to walk around with it. It's put in their property after we test them, but it's got all of the local county health department's information on it on the back side. So it's got Corey's information, the clinic, any follow-up that they need that we talked about. And then it's got a lot of the community resources that we regularly link to on the back side. It's got my information as well. So we've gotten a few partners that way, where they've called me after release and they're like, hey, I'm finally out. This is this person's phone number. Generally, if we can get first, last name, date of birth, we can find them even without the phone number. So that's one way that Corey was able to do a really good job at trying to move around. That was those rack cards that are put in their property when they're released. We know we throw a lot of information at them in those 3 sessions or 4 sessions. So that's like a nice way for them to follow up. So that's one way we do that. And then as well with doing the re-interviews on Vicilin shots 2 and 3, sometimes they're able to get calls into family members. And a few of them have said like, oh, my sister was able to get my phone, here's this person's number. So we just encourage them any way possible to reach out. But generally with a first, last name, and date of birth, we're able to locate that person.
Thank you. Switching gears a little bit, this looks like it's more of a question for Erin. What are the logistics that would go into a jail becoming eligible for 340B if their medical provider is a private contractor? What kinds of agreements or policies would need to be in place between the jail and the contractor?
It's a comprehensive question. I would say step
Should I put it in the chat for you?
No, I got it.
Okay.
It's the money question. I mean, it's the all-encompassing question. I would make contact with the facility. So who's the warden, who signs the contracts, who signs the agreements, who is in charge at that facility. You're going to eventually need to engage with the medical contractor because they're the ones that are providing the services, but you need to get to somebody at the facility. So a county employee, whoever's in charge, usually, like I said, usually it's the warden. So I would connect with them, establish that strong relationship. I would let them know about, the partnership that's available, the public health and Department of Corrections or correctional facility partnership, and about 340B, and if there is a way to confer eligibility. I also wanted to remind everyone that local health departments or sub-grantees cannot confer 340B eligibility. So the grantee or state level recipient of the eligible funds would need to confer the eligibility to the jail setting. So in this instance, if it's a local health department that the correctional facility is reaching out to, then that local health department would also need to bring in their state level partner, because HRSA for 340B eligibility will reach out to the PI on the grant that's providing eligibility to double check that that is an eligible facility. Also, the correctional facility that's enrolling in the 340B program will need some information that only the state level administrator or the recipient, the grantee, will know, which includes a grant number. So depending on what correctional facility we're talking about, whether it's a jail or a prison, my guidance is the same, is still make a connection with not the medical contractor, with the governing official at that correctional facility, and really work on that partnership. You might need to bring in your state friend. If you are the state person, you don't really need to bring in any other partners unless there's other stakeholders that would be involved in this. And then really do the education, share the 340B resources. NCSD has a 340B 101. We can share that in the chat. We also have 340B for ending the epidemics. We have quite a bit of 340B resources. Our colleagues at NASDAT also have 340B educational materials available as well. So really building up the capacity for 340B at the correctional facility. Lots of times it's kind of just a light bulb moment that needs to happen. Sharing that they can save money, sharing that they can stretch resources, sharing that they can purchase bicillin for 12 cents. Just sharing the ability that this program would allow them to utilize their resources in their facility. Sometimes there's MOUs, grants, contracts that outline the expectations, and you can email me and we can get into those. But first step, I would say make contact with the warden.
Thanks, Erin. And another question about some things that you mentioned. So you mentioned a host of in-kind things public health can provide to corrections as examples. Can these be listed out? So do you have any specifics you can share?
Yes, besides what's jammed in my brain, we will have a resource coming out in a couple of weeks that outline the in-kind that we frequently see. I also have a list that I have pulled out of the Office of Pharmacy Affairs Information System. If you go into OPAIS, Office of Pharmacy Affairs Information System, everything is public. You can view all of the covered entities. You can see who's active. You can see who has an STD designation, who has a hospital designation. There's about a dozen search fields, and you can actually pull up a correctional facility. So oftentimes I'll use the keyword search corrections or jail, and you can open their covered entity, their designation, and you can see what kind of in-kind they've received. So we'll have a resource published in a couple of weeks. You can email me and I'll send you my own personal reference list I use. And I can also show you how to search in Office of Pharmacy Affairs as well. If you want a little chunk of my time, I can show you that.
Thanks, Erin. Someone asked, do you have any peer worker programs integrated within your correctional facilities? This might be a Corey question. Or maybe Erin, if you know of any programs that do.
Will you say the question again? Peer programs. So formerly incarcerated folks coming into the correctional facility.
Do you have any peer worker programs integrated within the CFs? Yeah.
I have not heard of that model, but I would love if anybody's on and has.
We don't have any at our county jail. They do have all sorts of programs that come in, but none of them are peer.
And I think the problem with correctional facilities, if you're talking about a true peer, it would be someone who has been incarcerated and there's security processes and protocols. So you would need someone that is a peer, but peer far enough out that they've maybe been expunged or their security clearance would clear. They're not going to let a formerly incarcerated person back in the facility. You know, there's those considerations as well. But if we're talking about a peer in another form, you know, maybe someone who uses drugs or used drugs, then maybe does not have a criminal record. That, I guess you would have to define who's a peer in this setting.
So in response, someone also adds, we have a peer worker program with lived experience, but they were hoping to connect with other facilities that might have kind of that type of model in place. So if there is anyone, please feel free to connect with, is it Taryn? Did I say that correctly? Taryn, if you want to maybe drop your information in the chat for folks to connect if maybe they have something that they have going on that's similar. Thanks. So someone says in the chat, Pueblo County does have a jail-based behavioral services program with peers, but none with lived incarcerated experience. So kind of just some more information on that. What other questions do folks have? 340B things, some additional questions for Corey or Elsa for DIS implementation or how testing is being done for Corey? No? All right, well, I'm going to drop the event link into, the event page from our website into the chat. So if you haven't seen part 1 of the workshop series, the recording and slides are available here on the link. And then I'm also going to share, Karen, do you mind going to the next slide? Thanks. I'm also going to share part 3's registration link later this afternoon. I'll post it both on this website event page on our website, and then also it will go out in the weekly. Also coming up, we're planning to put together a service delivery toolkit available sometime in July. So I know Erin had mentioned the 340B 101 resource, the 340B for EHE, that in-kind list that we had some questions on. So we'll put all these items together kind of as in conclusion, here's some of the things that we talked about from this workshop series. And that will also become available in July on our event page for this website, on our website for this event. Part 3 is going to take place on Wednesday, 6/28. So that's in 2 weeks at 3 p.m. Eastern, and I will share the link. And unless there's any other questions or any other adds, Erin, I don't know if you want to add anything before we part ways. Feel free to connect with either of us, and we will look forward to seeing you there. Please also feel free to share your thoughts in the post-meeting survey that'll pop up when you exit out from the call. Erin, you want to add anything?
Nope, just thank you for your tireless work and good luck with all of your partnerships. May they not be difficult.
Thank you all so much. And thank you so much to Corey and Elsa. They actually joined us immediately after testing. So thank you so much for busting your butts there, just doing great work, and then also taking the time to share here with us. So thank you both so much. All right, well, we'll hope to see you all in 2 weeks. Thank you all.